Welcome to the Staying Active podcast.
All right, welcome back to Staying Active with Dr. John List. There he is. Look at this guy. And me, Derek. Today we're going to talk a little bit about some philosophical things, some, practice type things. Things like, John, what are the deep questions people want to know? What do you believe about modern medicine? These are the questions people have. How did you do this? Why did you get into medicine? These are the things people want to know. But unfortunately, I have other questions. So we're going to cover some of those things and some other things that I want to do too. And so,
Perfect.
one of some of the things that we talk about all the time kind of turn into just like business as usual sorts of discussions. But if you were to go to another practice, another facility, that would probably be a weird thing to discuss. Some of the things being like, we talk a lot about how our waiting rooms are mostly for show. They're nice to have, but people don't spend a lot of time in there.
Right.
Things like, patient care as a metric. What does that even mean? Things like that. We talk a lot about quality. We talk a lot about the people we have, not about the people we want or need or whatever the case is. But we talk a lot about taking care of our patients and making sure that they understand what that means, not just from a reactive medical standpoint. And so I had a bunch of kind of pointed questions for you that are mostly based off of like modern medicine as a whole, not in like practice per se, but in procedure.
Sure.
And so some questions I have, just because you've spent time out of this system before.
Yes.
I'm really curious about like why do patients seem to spend more time in the waiting room in many cases than with their doctor?
That's a good question. So you're right. I have seen both sides of, kind of more traditional primary care, and then kind of what I would characterize as a slightly more innovative model. Slightly maybe underselling it, but a more innovative model. It really goes back to the way that the system is structured incentivizes more patients to be seen. And so when you have a schedule in a traditional model that incentivizes 20, 25, 30 patients seen per day, because that helps,
A lot.
financially, the practice, it doesn't leave a ton of time for each patient. I think it takes certainly longer than probably the standard 15, 20 minutes to really get into the meat of a conversation with the patient. But say even if you're really efficient and you can really just, all you need necessarily is 10 minutes face to face with the patient, that still doesn't take into account the variables of, some patients take longer to get there. Some patients arrive a little late. Some patients even have a hard time walking down to the exam room. The time that it takes to intake a patient and do their vital signs, the time it takes for a patient to kind of check out. And so inevitably there's backups, and it's sort of like a traffic analogy of, even if there's no accident, a road with many, many cars is going to see delays. And it's a very similar thing with traditional medicine, whether it's primary care or specialty care. And therefore, patients spend a lot of time in the waiting room, kind of waiting for their sort of turn at sort of being traffic in a sense.
Yeah.
And there have been efforts to try and make it what we call a pull system. It comes from this like Toyota manufacturing, more like lean manufacturing type of process. Like they shouldn't even ideally need a waiting room. Like you take the patient when they're ready, and you just bring them back to the room, and then you move around the patient so the patient doesn't have to move. And all these things sound really great on paper, but practically speaking, when you have such a high volume of people to see, it inevitably doesn't work that way.
Yeah, it's sounds like a real problem. I mean, I think the statistics, at least in Connecticut, are pretty interesting for average patient populations across physicians. We're looking in the 2,000 to 3,000 range for
Yes.
a patient population. And so that's pretty insane. Like you're talking 25 people a day plus, if you've got any quotas for new patients, that's,
Right.
that's the old saying, right? If it's not about, oh man, there's, you know, this traffic, it's so bad. No, if you're in traffic, you are traffic. And
Right.
that's part of the problem, is that there's just so many people,
Right.
and only so many physicians, at least in
Hmm.
this case, one person to 2 or 3,000 people is
Right.
tremendous.
Hmm.
When did things get so rushed?
That's a good question. I think it's sort of twofold. It's supply and demand sort of issue. And from the supply side, the amount of physicians going into primary care has decreased proportional to the population. A lot of just general internal medicine physicians are actually moving towards hospital medicine and being hospitalists as opposed to outpatient primary care docs. So the number of physicians has decreased, although quote unquote mid levels, which is kind of a pejorative term, but APRNs and PAs have sort of filled the void in a lot of states from that perspective to try and increase the number of providers. And then from the demand side, a lot more and more responsibility is being thrown at the primary care physician as sort of the provider who can't really punt it to somebody else. Like, right, you're kind of like if something needs to be done, even if you're sending a referral, like you still own that patient, you're still ultimately responsible for that patient's health. And so there is a lot to be done. You kind of do everything from, psychiatric care to skin care to general preventive care,
Yeah.
which is necessarily time intensive. And so it's really a strain on both supply and demand. And with Medicare, it's sort of a long story short, with Medicare reimbursements actually being decreased for primary care physicians across the board, the financial incentive is to make up for the lost revenue by, again, seeing more and more patients. So it's sort of a vicious cycle in that sense.
So it sounds like twofold, right? There's, well, maybe even three, right? There's a incentivization problem from the very get-go, right? You have fewer people who want to be primary care physicians. There leads obvious, holes there in that space,
Mm-hmm.
which leads to the physicians that do exist, having a huge burden for population.
And then that leads to less people going into primary care, and it feeds the system even more, right? So it's like it's something's got to break the cycle.
Well, I like to think that what we're doing is kind of going in that direction, and a lot of it is being considerate of, at the end of the day, this is a service, right? And you can call it whatever you want, but it's a person who's leveraging time to spend with another person. And if somebody like you, if the doctor is not considered and their welfare is not considered, you're going to do a bad job. If we overwhelm you, you're going to probably provide pretty poor care, because something's got to give, right? You've got a family, you've got a social life, then, you also have work, and all those things can be important to you, but there's only so much time in the day.
Yeah, and it's exactly right. And that's where we see even really good, well-trained physicians, burning out and imploding in a system that they're just not set up for success in. It's not necessarily them or their failure. It's just, at a certain point, it's untenable for most people.
Yeah. Do you think that's kind of a guarantee with those types of numbers when you see a volume of patients like that? Do you see like, look, there's going to be some bad situations, or maybe just like, undesirable outcomes as a result?
Yeah, I don't think it's a guarantee, but I think it's definitely significantly more likely to have, if something falls through the cracks, or burnout, or from a provider standpoint, patient dissatisfaction, absolutely significantly more likely. Not a guarantee, and some people do it, actually pretty well, but they're certainly the exception rather than the rule. And typically their patient panels are full, lickety split, and still they don't have the time that they probably want to spend with people.
Yeah. Somebody that comes to mind is, another one of ours, Dr. Barbara, she
Mhm.
she had a pretty large patient population prior to
Yeah,
joining with us, and I won't speak on that too much more, but I know that, she did a lot to make sure that she managed that well, and I know that she
yeah,
did, but I know it was to her own detriment.
hmm,
And so that's
absolutely.
just unfortunate to know that, it can happen, it can go well, but somebody's got to pay.
Hmm.
Um, so that's interesting because one of the ways that I see a primary care physician is almost like a central hub of health and a way to coordinate a lot of the noise and not necessarily from the like logistics perspective, but to help you understand, what all these specialists are saying and doing
Hmm.
and help you with the labs that come in and the diagnoses and the prognosis. Like, there's something that's happened and there's something you got to do about it and it interacts with this thing and then you got to do that thing and you got to go over here. Having an advocate that is your physician, I think, is kind of like a life hack. Don't you know what I'm saying?
Yeah, I would agree. I think it's, I use the analogy, I used to use the analogy that we are the quarterback of the patient's care, to use a football
Mm,
analogy, right? Kind of the coordinator.
I like that.
But I recently switched to, since we focus a lot on preventive care, we're more playing defense in a sense. So I like to think of
Yeah,
myself more as the middle linebacker of the patient's care, which it's not as powerful analogy, but it fits a little bit better. Um, but
not
you're
enough
absolutely right. I think
appreciation
that's a
for middle
good.
linebackers.
I think that's a. I think it's a more apt analogy. Um,
No, that's
but it's
very
true.
good.
It's in, and come it really, if you think about it from the standpoint of patient harm, the primary care physician is the most dangerous person, the most dangerous physician of all, because you see patients that are typically pretty healthy, and therefore, if you do something wrong, the patient, their health can decrease by a significant amount. If you are, say, a trauma surgeon, and a patient comes to you with 3 gunshot wounds and a stab wound, they're already basically dead, and you can't cause that much more harm to that patient.
Mm,
All you can do basically is try and help them. And most of your intervention is therefore positive. Whereas a primary care person, if someone comes to me, they're 98% healthy, that 2% is very difficult to get. But that 98% drop off, if I prescribe a wrong med or they're allergic to it or I misdiagnose them, can cause significant harm. And therefore, I think it's really important for A, providers to realize that, and B, patients to realize that as well, to pick a really good primary care provider that you trust, um,
yeah,
and that kind of has your best interest in mind. And that's maybe a little bit of a deeper philosophical thing, but just wanted to put that out there as well.
I think that's great. I was actually planning on kind of going down this road, and I'm always happy when voluntarily walk down the hard path rather than me having to spring it on you. So this is great. So if you could keep that up, that'd be great. Um, you know, I don't want to harp on patient population so aggressively because it's not our only value proposition at Active Health. But it is a significant one, and I think a lot of it, at least for me as a non-physician entity in the organization, it represents a lot of ways in which we can guarantee things will go well, or at least
Hmm.
push them to a more likely go well,
Right.
as it pertains to like the personalization of medical care versus simply following clinical guidelines. And we have touched on that kind of like outside looking in as far as like, I've got strong opinions about things. You certainly have, some good opinions on like testing protocols and just like the generalized approach to like even language in certain situations. So I kind of wanted to touch on that a little bit more, just like kind of directly, like what separates that personalization in medicine versus like the following of clinical guidelines. Because for me, it feels really easy if you got 2,500 patients to just follow clinical guidelines and not necessarily know this person all that well.
Absolutely. I think that really gets to the crux of the issue, is that time spent with the patient is the differentiating factor, um, between, treating everyone as a sort of the same, and treating a heterogeneous population as homogeneously as you can, versus being able to personalize your recommendations and your treatment to the patient in front of you. And it's really just takes time. Even a new patient, you spend an hour with that new patient as opposed to 20 minutes, you're going to get a significantly different outcome. And I think probably in virtually every case, it's going to be a significantly better outcome from the standpoint of the patient is buying in, kind of what they're doing outside of this clinical visit a lot better. And from our standpoint, I mean, I would venture to say that any physician would give better care in our model versus another model. And I think also one of the things that, we've kind of been physician centric thus far, but I think one of the really important pieces is that we're able to leverage other people in the healthcare field to the top of their sort of license to offload some of the other things that I'm not necessarily an expert in.
Yeah.
And so we know exercise is really important. We know eating well and having good habits is really important. And maybe my knowledge is to a certain extent in those fields, but it's, I am not a trainer and I am not a health coach, but having those people at our disposal to then spend additional time with the patient, reiterate some of the points that we're making, really makes me more effective. It makes the patient's care more effective, and more coordinated, and absolutely provides better care. I mean, we're obviously talk about all of our patients and clients together, but easing that burden so I don't have to talk about every single thing from a preventive care standpoint and every single habit for every single visit also allows me freedom to talk about other things that matter. And so I would, maybe it's not a far limb to go out on, but I think even like the worst ranked physician, however you would subjectively rank that, put them in our model, and I think they would thrive.
Yeah, it's interesting that you bring up the like multiple, experts across multiple fields, because that's essentially like the preventative aspect of this, right? We're able to integrate not just the physician, but physicians in with strength coaches and trainers in with health coaches, and quite a few other modalities, if you include specialists and therapists, physical therapists, things like that. One of the things that I think is really, really interesting that this model does really well in practice is you talk about not having to cover everything in complete detail, to include like here's some action items to execute on and then the accountability and follow-up, right? There's also the fact that, if things are going well with your primary care physician, you're probably going to see them maybe twice a year, if you really need to, right? Once a year is not uncommon. And when you're a member of a practice like ours, one of the cool things is you're going to see us a lot, not necessarily seeing the physician all the time, maybe in passing in the hallway or, just saying hi, but you're going to see somebody a lot, and they're going to be able to pass on information to the physician. I can remember an instance for me specifically passing on some information to you about, a patient that we have who they engage in all the services, and they just had a cut that like would not heal for whatever reason. And that's something that she had no intention of talking to anybody about. I'm like, you know what? This is information we can do something about this. We can intervene before this becomes a problem. And, that's like a small example of the type of communication and integration that can happen when not only are there like smaller patient populations, but there's more people to take care of this individual. Just really, really interesting. And again, I said I wasn't going to beat this to death about patient population, but here I am with, my propaganda, I suppose.
No, that's okay. And I think it also gets to the point, and the time piece also sort of leads into the more time that the broader team, including the physician, the trainer, the health coach, are spending with you, the better they know you, and therefore any deviation from baseline is much easier to identify. Of like, something's off with.
That's right.
With Joe Schmo today. It seems just like something's a little off. You mind taking a look, or hey, I don't know, Joe Schmo is the same patient. Having trouble. Like they have like some questions. They've been doing this training program, but now they're having some issues with, their ankle. Can you modify things to kind of so they can work around that, still train? Like these types of things that are sort of second nature to us once we get to know a patient. And I think at least from doing a whole bunch of meet and greets and things with patients, that seems to be something that people value quite a bit, is having a place that knows them. They walk in the door, hey Joe, how are you? Good to see you again. That kind of thing, where you feel like you're known.
Yeah. It is really interesting because of the time capacity is such a factor, right?
Mhm.
You have resources as a physician, me and the training side, I have resources in physicians, in health coaches. It's just interesting from the standpoint of not necessarily accountability, but collaboration is the word I would use, right? I don't have to be the end all be all. Neither do you, neither does any of the health coaches, right? There can be multiple perspectives from like driven from the area of expertise and the data that's collected on this individual from those perspectives. And I just think that's a really helpful thing. It really is a game changer for overall health outcomes.
Yeah, I fully agree.
So, I guess the real question is, a model like ours, why doesn't it exist anywhere else? That's the real question. Like fitness, nutrition, coaching, medicine. It doesn't feel like a huge stretch to say that they should not live in separate silos. They should be in one place.
Yeah. So I think the answer is probably twofold. I would say more conceptually, I think of it similar to the problem of wheels on luggage. Now it seems so obvious. Oh yeah, let's put wheels on luggage and right. And so from our standpoint, oh yeah, it seems so obvious. Let's just integrate all of these things that we know beyond a shadow of a doubt make a difference, making you live longer, healthier, and feeling better. So like the wheel was known, the luggage was known. Putting together here, like, yeah, we know exercise is very good for you. We know which exercises are very, very good for you. We know by and large, dietary general principles are very good for you. We know certain medical things are really good for you, or we're putting these all together. So there's sort of like the novelty and the combination, I think is one thing. And just think it was kind of people more like the innovation, it wasn't, that bigger step wasn't kind of yet taken across the board. I mean, I'm almost certain there are some other places around the country that do this, although obviously ours is better than theirs. So I'm just talking it just, but no, I'm sure there are other places but it's not like a ubiquitous, very large model. I think that's one reason. I think the other reason is really comes down to as for right now is sort of like the financial aspect of things, is that it's difficult if you are just relying on insurance reimbursements, it is very difficult to do this type of model. And so, having a membership based model is something that allows us the freedom to do this with our patients. And I think, sort of my pipe dream down the line, because we do, as you were alluding to at the beginning, we track religiously virtually every metric that we can get our hands on. And being able to prove down the line that we do take better care and our patients do spend less healthcare dollars because they're healthier and make better decisions and all that type of stuff, I think would be useful knowledge to an insurance company to then be able to pay for this type of thing. And it would be better for providers and better for trainers and better for health coaches to provide care in this type of model. And that may be the thing that sort of reinvigorates primary care back to the forefront as like the cool place that people want to be. And so that's at least how I kind of think long term about the model. And I know that I'm sure you have your kind of vision as well from that side of things, which I'm obviously very curious to hear. But I think those are kind of, to get to the root of your question, I think those are the two big reasons why it's not more ubiquitous.
Yeah. Well, it's interesting to kind of just like continue with that. The some of the things that we talk a lot about is like ultimately like metabolic disease is like as a general concept, right? We're talking about preventable disease, lifestyle disease, some of which can be, I'm sure a lot of it is genetically derived, some of which is like lifestyle derived. But we often think of that as like, preventable in some aspects. And I just think it's interesting to have all of those different touch points and then to consider on like the kind of like straight up question, like, is it actually cheaper to, or less expensive, maybe is a better word, to participate in a prevention based program rather than it just being like generally healthier for you? And I'd be interested in your, like, from your experience, what you've seen with like, you're like, look, all I can do is respond to this given the resources. You've got to do whatever, or whatever the case is. Does that make sense?
It does make sense. And I think so prevention in general is a very difficult thing to prove. And that is one of the reasons why our healthcare system is oriented towards treatment of disease as opposed to prevention of disease. It's very easy to say like, oh yeah, you had a heart attack. I put a stent in your artery and you did not die. Good for me.
Yeah.
It's very difficult to prove, hey, you told me a while ago and you walked me through these dietary patterns to improve my protein intake and I added skeletal muscle mass and therefore I never got a heart attack. It's very difficult to prove that they would have if they had done something different other than taking like a large population-based study. So on an individual basis, preventive care without a time machine is virtually impossible. But I think the system, especially in more of a traditional model, is set up to be reactionary, because that's kind of what you get graded on. That's how you get judged. So no physician's going to get an award for not prescribing a medication that would have caused harm, because you could never prove that. But if you say you have a person with high blood pressure that's very slightly high and you decide not to prescribe medication, but down the line they have a stroke, they're going to look at that and say, oh, yep, you did not prescribe this guideline in medication and therefore you're liable. And so the incentive structure, the reactionary structure, the time-based like the limitation of time, and treating everyone kind of as a guideline, again, all are kind of are incentivizes the provider to provide that reactionary care and to practice like more defensive medicine, to be honest, which often leads to more medications prescribed, more referrals sent, more healthcare dollars spent, and I think that's ultimately a broadly speaking a disservice to our patients and to the industry.
We're running short on time here. We got a quick one today, but I figure we should probably cap this off with kind of a little like summary sign off from you. And if you were to simplify it, you've been in a different situation before. Now you are with us at Active Health as like a huge part of what we're doing. How should healthcare be? What should healthcare look like?
That's a great question. I'll try to keep it short because I've got a lot of thoughts on this. But based on what we were talking about, healthcare should be individualized. It should be friendly. It should be convenient. And it should be provided by people. And I feel very strongly about this last point, which we have not touched on. But it should be provided by people who practice what they preach. Physicians, trainers, health coaches need to taste their own medicine. They need to eat their own cooking. They need to abide by the recommendations that they're giving their patients. And that is very important. I think we do all of those things. I think we provide something that is extremely convenient. I think we provide something that patients enjoy coming to. It is friendly. It is a place that people don't dread coming to. We practice what we preach. And I think ultimately when the time is spent in those domains, what comes about is better patient care, better patient outcomes, better provider satisfaction, ultimately kind of satisfying what they used to call back in the day the triple aim of healthcare, which nobody has really thus far done. So I think that is sort of my ideal for what kind of healthcare should be. Maybe adding a little asterisk to add on, it should also be interdisciplinary, which I think kind of falls into those other categories. But I'm curious your thoughts as well on that as kind of the very last piece.
Wow, that's a tough one to follow. Um, as a user of medical care, not a provider of medical care, but a provider of preventive care, and a user, I I really appreciate the idea of interdisciplinary quite a bit, multimodal, having multiple solutions for similar problems, ultimately leading into the individualization of care. I think for me, the biggest piece for medical care kind of stems from the assumption that whomever I'm dealing with, that physician is a subject matter expert in modern medicine, right? That's my expectation. So I don't want to use that as one of my pillars per se, but I want this person to be an appropriate and consistent communicator. I do not have the same experiences that you have had. I do not have the education that you have had. I've come from a different place, and I understand all of these words, all of these ideals, everything differently. Some incorrectly, some more nuanced and variable than you might, try to. And as a result, if you as a physician are not patient and communicative and willing to understand me, I will likely have a bad experience. I will likely leave having felt unheard, misunderstood, or simply straight up just told that I was wrong and I should stay in my lane. As a user, that is probably the strongest factor for me, is that I want to feel like you're willing to listen to what I have to say. You're willing to take the things that I have learned or believe in and help me either understand, point me in the right direction for education, or re-educate, but in a way that's not going to belittle me or kind of push me away. And all those things take time, unfortunately, for most physicians. So that's I mean, for me, it's all personal, baby.
Well, thank you for sharing that. That's useful, and I would agree.
Yeah. Well, unfortunately, we are out of time. Sorry for all of you to have heard my tirades on the requirements of primary care, but this has been really good. I'm glad we got this one out of the way. I'm surprised we didn't do it sooner, but this is awesome. As always, thank you guys very much for hanging out with us, listening to Staying Active with Dr. John List. That's him right there. Wow, what a guy. And me, Derek. I appreciate it. Thank you very much.